Morning, everyone. Welcome back to Monday's Learn Anatomy Online. I hope you had a good weekend. Yeah, I've got quite a bit to get through today, so hopefully we'll be able to cover all of the nerves. I was going to do nerves and blood supply, but there's actually quite a lot of detail to go into with the nerves, so we're just going to do a whole show just on that today. We've got a few of our regulars in. Morning, Simon. Coffee and anatomy. Carlsberg don't make Mondays, but if they did, they'd be Anata Mondays. Exactly. Of course they would. Hey, good to see you, Sarah. I haven't seen you for ages. Welcome. Becky. Hi, Becky. And we've got Julian, some of our usual crew, and a couple of ones that haven't been in for a while. That's good. Cool. So, just wanted to give you a bit of an update on this. So we got the Anatomy Lab workshops, still got some spaces left if you wanted to come along. They are at the end of March, beginning of April. King's College is end of March, and then Keele is beginning of April. So if you fancy joining me in the Anatomy Labs, just go to clinicalanatomy.education and you can book there if you want to come and see all of this stuff in real life. Cool. Right then, let's get going. So we've got a little bit of a catch up to do first. Just get rid of that. There we go. So we did a little bit on the hamstrings last week, and I just wanted to go into a little bit more detail on those today, and just kind of finish off that section of the muscles, and then that will help us as well when we get to the sciatic nerve a little bit later on, because you'll have a bit better understanding of where everything is. So, like I said, we did go over these, but the images on the video that I'll show you on this one, I think the quality is a bit better. The dissections are a bit better, so you'll be able to see things in a bit more detail. So this is the usual picture that you will see. We talked about this last week. So all of your hamstrings attach up on your ischial tuberosity, and we talked a little bit about the kind of injuries that you'll get in those areas. So if you have a complete rupture of a muscle, it's usually at the OTJ, which is the osteotendinous junction. So that's where the tendon attaches onto the bone. And basically, it's I think it was Neil that said last week, is that an avulsion fracture? And yep, that's exactly what it is. So basically, the tendon will pull away, and it will come away from the bone. So that's usually where you get your full ruptures. And in the hamstrings as well, they usually occur at the ischial tuberosity, so this end, rather than down by the knee. That's where you would usually find that. So the thing is, though, with these kind of injuries, the person will still be functional because you've got other muscles that bring about hip extension and knee flexion. So if you think if it was the semitendinosus that ruptured, then you'd still have another two hamstrings that would help move the hip, plus the glutes, and then also flex the knee as well. So you don't automatically lose complete loss of range or something like that. But what you may notice is that, not straight away, but usually a couple of days afterwards, you'll have severe bruising around this area, and it's often not where the injury site is. It's below that because of gravity and the blood coming down into the leg, and sometimes as low as the heel. So you can have bleeding into the heel. So so that's the complete ruptures. And then this area here where you've got the tendon bit there, which is the white bit, and then the red bit, the muscle, that's the where the muscle starts to change into a tendon. It's the musculotendinous junction, so the MTJ, and that is a weak point for the muscle because of the change of structure. So you're going from a contractile tissue, so the muscle, into an elastic tissue, which is the tendon, and at that point where it crosses over, it's not like a line where all of a sudden it's muscle and then it's tendon. It's all weaved into each other, but you may get injuries into those areas as well, where you'll get tears. And it's funny with the with the kind of language that we use with these, I don't tend to use the word tear with patients or clients. I tend to use strain instead, because tears can give you a really bad image in your mind. So, because even a low grade tear, where only a couple of muscle fibers have been injured, just using the word tear may make that person feel a bit vulnerable and a bit worried about that particular region of their body. So yeah, tend to use the word strain with clients, but the really it is a tear of the tissue. So usually you'll feel something go, you'll feel a tear, you'll feel a pull, and depending on the severity of it, will depend on whether there is a palpable gap. So when you're feeling in this area, so these are the areas to feel basically. So up here on the musculotendinous junction, and then down here as well. Okay, so obviously there's two ends of the muscle where they both attach. So those are the areas where you'd need to concentrate on. If it's a more significant tear, then you will feel a dip in the muscle, a gap in it, and usually it's quite tender on that spot. If it's a very minor injury, then you may not feel anything, but they will feel that it's sore in that region. So those are your key areas really for injury. So around this musculotendinous junction, and then the osteotendinous junction right at the bottom of the muscle. So we've got two hamstring muscles on the medial aspect of the thigh. So this is the inside of your thigh at the back. So there's your bum bones just there, and then we've got semi-membranosus, semi-tendinosus, and you can feel the tendinosus tendon really easily at the distal end near the knee, and we were looking at that last week. So have a look at those videos if you want to go over that again. And then biceps femoris has got two heads, hence the name bicep. So we've got a long head that attaches on the ischial tuberosity, and then the short head attaches onto the femur, and they then both join together and then come down onto the fibular head. Okay, so we're going to have a look at that in a bit more detail. Let's just switch to the videos. Just get rid of that one. Here we go. Okay, so this is a real life version of what we've just seen. So you've got your ischial tuberosity up in this area here. There's your greater trochanter. So we're going to start adding the layers of the muscles on now. So here we go. So these are your hamstring group. So if you think about the picture that we just saw, it looks a little bit different. They all look pretty much like one. That you can just about make out the distinction between the muscles as you come down. But if we go back all the way back to some of the first sessions that we did when we were literally just taking off the skin, and the whole leg is wrapped in fascia. And then each of these muscles will be wrapped in bundles of fascia as well. So it doesn't look as clean and tidy as this in real life. This has obviously been dissected back so you can see the individual muscles a little bit clearer. So we've got semimembranosus and tendinosus on the inside. So that's on the medial aspect. And then biceps femoris, so that's this one on the lateral aspect. And we'll have a look at those now. I'll pause it at different bits just so you can see. So there's your biceps femoris tendon. So you can see the long head coming down here, and then the short head here, and then they're both coming together to attach onto that fibular head just down here. Okay, so on the biceps femoris, this is the area, so that musculotendinous junction area where you usually get the injuries. Okay, so it's usually at that distal portion. There we go, so semimembranosus and semitendinosus. And what it will do in a second is it will take them out so we can see each of them individually. So there's your semimembranosus. So this is what it usually looks like in the textbooks. This is the image that we used the other week from the Trail Guide to the Body. So if you're wondering where I get my pictures from, it is there. And the videos are from Acland, ACLAND. So if you want to, you can purchase access to all of these videos, and so the reason why it's called semimembranosus is because it's half membrane. Okay, so that long membrane there, and then there's the muscle there, so you can see the difference in the tissue as you go through. So it's a long flat membrane all the way up into the ischial tuberosities. So there it is there. There's the attachment there. And then it comes down onto the back of the, just move me out of the way, back of the tibial condyles. So tendinosis ends up on top, so it's more superficial, and there's the tendon just there. So if I just pause that there, just go back a bit. So this is the one, I just play that through. This is the one that you can feel a bit easier. Just wait until we get down to that tendon. There we go. Okay, cool. So if you have a feel on the inside of your knee, so the knee crease, scrape your heel along the floor or something like that, so that you activate your hamstring muscles, because that's what they do. They flex the knee, and then you should be able to feel a really thick tendon that is really superficial. So literally just right underneath the skin, and that is your semitendinosus tendon. And then depending on your leg, you might be able to feel underneath that tendon, and there's another tendon underneath it, that's semimembranosus. So tendinosis is on top, it's more superficial, so you can feel that one a bit easier. And that one is half tendon. Okay, so it's got a really long tendon on it. There we go. So half tendon, semitendinosus. Ischial tuberosity attachment again. And this time it comes round to here. And that's the pezanserine or pezanserine. And that's where your sergeant muscles attach. So sartorius, gracilis, and semitendinosus. And then the last one, biceps. Reason why we've gone over these is because you need to know where these are for the sciatic nerve later on. So there's your long head of biceps just there. There's the short head there. And then they both converge. So ischial tuberosity for the long head. Back of the femur, the linea aspera for the short head. And then they then both join together and attach down onto, which we'll see in a second. So they join there and then all the way down onto the back of the fibula. So the fibula head, which is buried under there somewhere. There we go. You can see it there. So that's where that attaches on there. Okay, so that's a bit of a recap of the hamstrings. And now we're going to have a look at the nerves. Okay, so hopefully all that's okay and that will make sense. If you've got any questions about the hamstrings, then give me a shout. Or I have missed a few welcomes. Morning, Stevie. Morning. We have Facebook user. Good morning. If you haven't clicked on the Ecamm link to share your details, then we just get Facebook user. So thank you very much. I've no idea who you are, but thank you. And then Neil, good morning. Tristan, don't worry, mate. You haven't missed much. Just a recap. And Penny, good morning. Oh, there's a few this morning. And Fiona, hey, welcome. Good to see you, Fiona. Cool. So we've got quite a few people from the diploma on this morning, which is great. So we've talked about this over the last couple of weeks. There's compartments for the leg, which is below the knee, and we kind of know about those because of something called compartment syndrome. So you might have heard of that, especially in the lower leg. But you can also get compartment syndromes in the thigh as well. And basically, the thigh is split into different regions coming off of the femur. So, and each of those regions have then got different muscles in, and those muscles are supplied by different nerves. Okay, some of them are shared, but the majority of them are supplied by the same nerve. So, just going to quickly go over this again, just so that this should help you make sense of it in your head. So we've got this anterior compartment at the front. So anterior meaning at the front, obviously. And then posterior is at the back. So that's the green one. And then a medial compartment on the side. So there's fewer compartments in the thigh than there are in the leg. The muscles are a lot bigger. And then we've got these septum, which are like thin sheets of connective tissue that attach onto the femur and then come out onto the fascia that surrounds the whole leg. So if you, very similar to the leg and compartment syndrome in the leg, if you have a bleed in this compartment, because it's contained within the, just underneath the skin, and then each side with the septum that attaches onto the femur, it's going to fill that compartment. Okay, so it will kind of contain the injury, if you like. That is one of the things that that gives it the main problems, because as it starts to swell and fill with blood, because it's got nowhere to go, it causes some real bad pain, because of the swelling in that region. But in saying that, that pain is good because it alerts us to a problem. So if you, it's usually in traumatic injuries. So if you fracture your femur, basically, and then the femur nicks an artery, it will bleed into that space. Same in the lower leg. If you break your tibia, then it may injure the artery. So if that does happen, so if you're working pitch side with a rugby team or football team, something like that, and that happens, then you should see bruising, swelling, mottled marks on the skin. So it's a real clear sign that something isn't right. And that's a medical emergency, because if it's not treated really quickly, they will bleed out into that compartment and it will just fill with blood. So it's one of those things where when you work pitch side, it's kind of drummed into you about compartment syndromes, and that's the reason why. So if we have a look at the anterior compartment here, we've got all your vastus muscles, so medialis, intermedius, lateralis, as well as your rectus femoris and your sartorius. So all of those we've covered over the last couple of weeks, so hopefully you should know what those muscles are. Medial compartment, you've got gracilis, adductor longus, brevis, and magnus. Okay, so all of those are in that medial compartment. And then the posterior, biceps femoris, which is what we've just seen, semitendinosus, semimembranosus. So they're all the different compartments of the thigh. So if we now have a look at the nerves that go into those regions, there are nerves for each compartment, and the nerves will supply the muscles that are in that compartment. So it makes it easier to work out what nerves do what and what muscles do what. Morning, Al. Good to see you, mate. Good morning. What you need to remember with the nerves, and we go over this every time we cover them, you will have motor branches, and these supply the muscles, and that muscle supply is called innervation. So these innervate the muscles. So if you hear that term innervation, innervate, it basically means it turns the muscles on. So it's the switch for the muscles. Then we've got sensory branches, and these are the ones that receive information from the extremity and then send the messages along those sensory branches back into the spinal cord, back up to the brain. Okay, so we've got these sensory branches, and they're often called cutaneous nerves, and we'll look at the spelling for those in a second. And that's sensation from the skin. Okay, so around the skin and those superficial fascial layers. And then you've got articular branches, and these are sensations from the joints. Okay, so we've got these nerves, they all join together, and you'll see that in a second, and they share the same origins in the spine, but they either send information or they receive information from different parts of the body. And the articular branches receive information from the joint capsule, from the ligaments, and from the synovial membrane that's in the capsule. So your capsule is telling your brain what's going on with it. Okay, so that and they're all shared as well. And this is why you can sometimes get referred pain in odd areas when actually there's nothing wrong with that area. So the information we get is sometimes really useful. Sometimes it's not very useful at all. So it's really useful to know, especially sensory branches and motor branches, because if there is a change in sensation, so usually a loss of sensation, then we know that it's more likely that there is an issue with a particular nerve root or a particular pathway of a nerve. Okay, and same with the motor supply. So if there's if we know that a particular nerve supplies the anterior compartment and then all of a sudden you can't straighten your leg, you can't extend the knee, then we know it's likely that there is an issue in that particular area and in that particular nerve. So it helps us whittle down some of the problems that we might see in clinic. So the first one is the femoral nerve, and so obviously anything with femoral in is to do with the femur. So we'll have we've got arteries and nerves in this region, and they're all around the femur. So if you think about biceps femoris, rectus femoris, all of those are named because of the region that they're in. They're in that femoral region. So I'll just move me out the way. So your femoral nerve, I'm going to have to cover a bit of the hip to show you how the effect on the knee, because seeing the nerve in isolation is a bit confusing. And but what will also happen, not with the femoral nerve, but with the sciatic nerve, this session will join up the nerve session from the ankle and the foot, because they obviously join together. Okay, so that the femoral nerve though doesn't, well, the motor part of it doesn't go below the knee. All right, so it only supplies the front of the thigh. So the femoral nerve will split into two divisions, and I'll show you the images of this in a second. And you'll have an anterior division, so one going at the front, and then a posterior division coming behind. And there is there's an artery that splits the femoral nerve, and that's what gives the nerve branches their names of anterior and posterior, because it's how they lie over and under that particular artery. Okay, so we'll have a look at that in a sec. So on the anterior portion of the femoral nerve, we've got two motor branches, so they supply the muscles, and then two sensory branches that receive information from the skin. Okay, so the motor branches are going to a muscle called pectineus, which we had a look at last week, and sartorius, which we've had a look at over the last couple of weeks as well. So pectineus, one of your adductor muscles, and then the sartorius, which is a bit of a flexor, external rotator. What else does it do? Bit of an abductor as well. Okay, so pectineus and sartorius, those are your motor branches that are supplied by the anterior part of the femoral nerve. Okay, if this is your first Learn Anatomy Online for a while, apologies. You've tuned in at the nerve day, which is always a tricky one. And then the sensory part. So this particular part of the femoral nerve receives information from the medial, or turns into the medial cutaneous nerve, and that means the midline skin nerve. So cutaneous is to do with the skin. So you might have heard of subcutaneous fat. It's basically fat that's underneath the skin. Okay, so medial cutaneous nerve is the midline nerve that receives information from that area of the thigh. Okay, so that medial part of the thigh. Then you've got the intermediate cutaneous nerve as well, and that's in between. So there's another nerve which we'll look at in a sec that receives information from the outside of the thigh, and the intermediate one is in between the two. So you got medial cutaneous, then intermediate cutaneous on the front of the thigh, and then the lateral cutaneous on the outside of the thigh. And we'll come to that in a second. So that's the anterior portion, so where it splits and it goes forward, of the femoral nerve. And then the posterior bit that comes out the back, we've got four motor branches, so they supply four muscles, one sensory branch, so skin of an area, and then two articular branches, so two joints. Okay, so the motor part is your quads. So the posterior section of your femoral nerve supplies your rectus femoris, vastus lateralis, vastus medialis, vastus intermedius, so all of those quad muscles. And then if you remember from a couple of weeks ago, there was a little muscle that when it contracts, it lifts the suprapatellar pouch out of the way as your knee extends, and that was your articularum genus. So those branches also supply that muscle underneath vastus intermedius as well. Okay, so you got articularis genus, articularis genum. Anything with genu in is to do with the knee. Okay, so we've got femur to do anything with femur in, femoral, femoris is to do with the thigh, and then genu is to do with the knee. Then you've got a really long sensory nerve, the saphenous nerve, and we'll have a look at that in a sec, because that that portion of the sensory nerve goes all the way down to the foot, and we've had a look at that when we looked at the foot and ankle. Okay, so we'll look at that again, and then the articular branches. So the femoral nerve receives information from the hip joint and the knee joint. Okay, so there's a nerve branch that goes off into the hip, to the capsule and all the ligaments and the synovial membrane and the knee, and they both send information back into the femoral nerve, back up to your spinal cord brain to let your body know what's going on with those joints. Okay, so the femoral nerve at the front in that anterior compartment. So if we just go back a couple, sorry, that's a lot of information all in one go. Okay, so that is this bit here. Okay, so that's your anterior compartment. All of that is supplied by your femoral nerve, and that's a good way to remember it. So that's why I've put that in there. If you compartmentalize it like that, just hopefully it makes it easier to understand. Okay, so let's have a look at some pictures. I like pictures. So we've got your femoral nerve where it comes from, L2, L4, and then this is the start of the nerve here. So if you notice here, is what is one nerve. So this is in the pelvis. We haven't covered that yet. We're going to do that in the next couple of weeks. So the femoral nerve just there. So this is abdomen area in that kind of pelvic bowl. One of the first branches it supplies is to iliacus, and we haven't covered that yet because that's to do with the hip. Okay, so it powers one of your hip flexors. That's a motor nerve. And then we've got nerve to pectineus, which we talked about before. And then this is where it splits. So you can see that blood vessels coming underneath. So that's called the lateral circumflex femoral artery. We'll look at that when we come to the blood supply. And the femoral nerve will split over that circumflex artery, and then the front part of the nerve is then anterior, the back part is then posterior. Okay, so that's how it is what it is. So this is your posterior division coming this way. So you've got a branch off to the hip joint, so that's the articular branch, and then you've got all of your quads, and then a little branch there going off to your knee joint. All right, so it's a mixed nerve of motor going to the muscles and sensory coming back in from the joint and the skin. We'll see it in a second. So if we have a look as we go a little bit further down, it then turns into this nerve here, the saphenous nerve, and that nerve is sensory, no motor. Okay, so purely sensory. But if you notice here, you've got motor branches coming off. So this bit here is all sensory, and then when it gets to here, it will be joined by some motor from the vastus medialis and intermedialis as it's coming back in. Okay, so if you think about the wiring of a plug, and you've got your earth, your live, and your neutral feed. I think that's what they're called. I'm not very good at electronics. Then if you imagine that with the nerves coming in to that region. So this region will only have one type of wire. It will only have the sensory wire, but then this one will be joined by a different type of wire coming in. So you've got your motor wires coming in that way, and then your sensory wires coming in that way. Hopefully that makes sense. So this all supplies the anterior compartment, which is one of the compartments of the thigh. Okay, so there's a picture of it. These are the pictures that you might have seen in the books before. So you see it coming from L2, L4, and then coming down, and then it comes underneath this ligament here, which is called the inguinal or inguinal ligament, however you want to call it. We'll look at that a bit more detail when we get to the hip, so don't worry about that too much now. And then these are the branches coming off. So you can see how it's supplying all of the quad muscles, pectineus, sartorius, all of the muscles that we talked about. And then this is the long sensory nerve, the saphenous nerve, coming all the way down here. Okay, so when we look at the sensory supply of the femoral nerve, if there's a problem with the sensation, then this is the area that it supplies. So the front of the thigh, okay, all on the front of the thigh. So if you have a weird feeling on that middle part, and this is where the intermediate cutaneous nerve comes in here, and then the saphenous nerve down here. So anywhere on the front of the thigh, and then down the inside of the calf, so the medial aspect of the calf, that is all from femoral nerve L2, L4. Okay, so and that's what a posterior view just there. So it's that kind of medial aspect of the calf, medial thigh, and then anterior part of the thigh as well. All femoral nerve. Hopefully that makes sense. Okay, let's have a look at that for real then. I told you these are heavy ones. Right, let's go. So this is the femoral nerve. Bit of an orientation first of all. There is your lumbar vertebra. Okay, so you can see the discs, and then you can see the vertebral bodies just there. And this is your iliac crest just along here. That's the ASIS. We've not talked about any of these because we've not covered the hip yet. So if you've just joined us, then apologies. We will go into that when we get to the hip and the pelvis. That band of tissue there is the inguinal or inguinal ligament, however you want to say it. And that muscle there that you can see is called the iliacus. Okay, so some of those you might have heard of before. Let me just get rid of that tracker. There we go. That's better. Cool. Okay, let's have a look at where these nerves go. So that, let me just pause that there. That chunky monkey there, that is your femoral nerve. It's a pretty thick nerve because of if you think about the muscles that it supplies, usually the nerves are relative to the muscles that they supply and the regions that they supply. So the nerves in the leg are huge. You'll see the sciatic nerve in a minute. It's as thick as your thumb. The femoral nerve is probably about as thick as one of your fingers. So it's pretty impressive. And then the white stuff, that white strip next to it, that is the tendon of the psoas major. Okay, so it runs really, really close to psoas. And if I just play that there, and then if I just pause that there, a nerve we haven't looked at yet, but we will do in a second in a bit more detail. So just so you don't get confused, we've not mentioned it yet, but that is the obturator nerve, and we're going to go into that in a bit more detail. So there's your psoas, that one there. So that's one of your hip flexors. That's your iliacus there in that pelvic brim. So that's another one. And then your femoral or femoral nerve is that one just there. And then there's your inguinal ligament just there. Okay, so that's where they all come through. Good comment there by Becky. Yeah, got to say I was shocked at how big the nerves are at the cadaver workshop. I always imagined them to be thread-like. Yeah, they are absolutely huge, and you'll see as well the upper body a lot smaller than the lower body, just because of the jobs that they have to do and the amount of neurons that are needed to innervate the different muscles. So let's have a look at the pathway of this. So this is the origin of it. So L2 to L4, and there's your psoas just there. So it comes out just behind that psoas muscle. And then obturator there. So there's your inguinal ligament or inguinal ligament. And then those are the little strands then of the fibers that are feeding in. So remember that image that you saw where it had split and then there were these nerve fibers coming off. That's basically what this is. So you'll have a branch coming off to sartorius. You'll have a branch coming off into rectus femoris. You'll have another branch coming off into vastus medialis. Okay, so that's where all of these are going. And if you remember, if you've done like fitness stuff before and you remember the the synapses between the nerves and then the muscles. So that's basically these junctions. This is the neuromuscular junction just there, and the like I said, the size of the nerve will be relative to the size of the muscle because you need more impulse into the bigger muscles. So you'll be able to see some of them a lot easier on these images. So these are the muscles that are supplied by the femoral nerves. So you've got iliacus, all of the quads, talked about that earlier. Well, it's got that there, pectineus and sartorius. And that was your femoral nerve. Okay, so it doesn't go below the knee. All right. The only bit of it that does is the sensory part. So the muscles that are, just switch that. So the muscles that are in the below the knee, nothing to do with the femoral nerve. Sensation, yes, because of the sensory nerve coming down, but all of the motor nerves finish here. All right, and that's really important when you're trying to assess things. So the next one is the obturator nerve. There are only 3, so don't worry, it's not that bad. So obturator nerve, right? Let's just move that there. That's bugging me as well. There we go. That's better. So obviously this is a nice clean image. Areas that we've not seen before because we've not covered the not covered that region of the pelvis and the hip. Sorry, just distracted by some comments. Bit like the fat 32 amp cable to my cooker. Exactly, because it needs more power. Yeah, that's it. That's exactly it. So if you remember where the femoral nerve went, so there was the inguinal ligament, and it went just underneath that. So the inguinal ligament runs from here, ASIS, onto the pubis. So if we imagine that the femoral nerve was coming down this side, it would go over the pubis, which is this bone here. Okay. This one, the obturator, goes through this gap here, and that's called the obturator foramen, which means obturator hole, basically. And then we've got these muscles here, the obturator muscles, and there's an internus and an externus, and we'll do that when we come to the hip. So your obturator nerve comes from exactly the same place as the femoral, so L2, L4, but it follows a different pathway. And if you see where it ends up, that's going towards your inner thigh. So this muscle supplies the medial compartment of the thigh. Okay, and that's it. It stays in that compartment. So let's have a look at that. So L2, L4, move me up there. So there we go. You can see it coming down here on this picture, and then through the obturator foramen, and then down. And again, this doesn't do anything below the knee. Yeah, so this is all inner thigh. So it splits into 2 branches again. So we've got an anterior branch where there are 4 motor nerves, 1 sensory, so feedback from the skin, and 1 articular branch. So the muscles that it supplies are pectineus, adductor brevis, adductor longus, gracilis. So all of those muscles of that medial compartment on that inner thigh. The sensory part is called the obturator cutaneous nerve. So obturator is all inside of your thigh, so adductor area. Okay, and then the other branch, the posterior branch, we've got 2 muscles, so 2 motor branches and 1 articular branch. So the obturator externus muscle is supplied by the posterior division, and the adductor magnus. Now the adductor magnus, you'll see in a second, is a special muscle because it is supplied by 2 nerves. There are 2 portions of the adductor magnus. We saw that last week. So you got an anterior bit and a posterior bit. So the adductor magnus anterior portion is supplied by the obturator nerve, and the sciatic nerve does the other bit, and we'll look at that in a sec. And then there is a branch going down to the knee, so you'll get feedback from the capsule, from the ligaments, from the synovial membrane, going up to through the obturator nerve as well as the femoral nerve. So your knee joint, the articular branches, there are two branches from the two different nerves. So we've got a femoral branch and then the obturator branch as well. Okay, so that's obviously useful to know. And then this is another similar diagram to the one we had before. So the thing that divides your obturator nerve into an anterior and posterior branch is the adductor brevis muscle. Okay, so we've got L2, L4. So that's your that's the origin. That's the roots of that nerve. Then you've got the obturator canal. So that's where it goes through that hole in the pelvis. Yeah, the obturator foramen. Then you've got your posterior anterior division. So obturator externus, which is a hip muscle. We'll talk about that in a sec. We've got a branch off to the hip joint before it splits, and then we've got the pectineus just there, adductor brevis, adductor longus, gracilis, and then cutaneous branch, so skin branch from the medial part of the thigh. So again, if you remember those wires, we've got sensory wires coming up this way from the skin on the thigh. Then you've got motor wires coming down to feed gracilis, to feed adductor longus. Okay, so it's again, this is a mixed nerve. So you've got both sensory and motor portions wrapped up in the same bundles. Okay, down here on this posterior aspect, we've got adductor magnus, and then we've got that articular joint. Okay, so it goes into the knee joint, the articular branch. All right, so that's your obturator nerve. Yep. So the adductor brevis is the reason why it's given that anterior and posterior branches. Yeah. So on the with the femoral, the split is really high and literally like on the join of that artery. But with this one, the split may be high, but then the muscle's a little bit lower. But that's how the anatomists have labelled it. Yeah, good question, Sarah. Cool. And then your sensory area. So if you have a problem with the obturator nerve, it will affect the skin on the medial aspect of the thigh. Okay, so all around here. So if you think about the femoral nerve, the femoral supplied the sensation of the skin on the medial aspect of the thigh, but not all the way around. That this one covers kind of nearly round to the posterior aspect. Okay, so it's a little bit more localized. The femoral is a bit broader, so it's around this kind of area, as well as down the saphenous nerve down into the foot. Okay, so all that medial part of the calf. So this bit here is specifically obturator, but there will be a bit of overlap. Okay, and that's just natural. So let's have a look at those. Let's get the right video on. So this is obturator. So we've had a look at this. We've been introduced to obturator nerve on the last video. So let's have a look at this in a bit more detail. So previously we were looking here. So that was your psoas, and then that one next to it, that's your femoral nerve. That's your inguinal ligament, and then there's your iliacus just there. Okay, let's follow this one through. Just pause that there. Okay, so iliac crest, inguinal ligament, and then the pubic bone just there. So half of the pelvis has been taken off so that you can have a look at the inside of this one. Okay, let's have a look. So you can see it coming through, and then there's your obturator internus muscle, and there's a little gap in the obturator foramen, and then that's where it pokes through. That's your pectineus muscle just there, and it emerges just underneath that. There we go. So you can see it just there. I'm just going to pause that there. So that hole there, if you remember the very first image we saw of the obturator nerve, and it looks really nice on the pictures, and it looks like there's nothing else there, but it's basically a gap just underneath you, just above your sit bones, so just above your ischial tuberosity. So ischial tuberosity would be about here, and then the obturator foramen there, and then that's where the obturator nerve will come through. So you can see the femoral's up here, so that goes over the pubis. This one goes under it, okay, and comes medially. Right, let's have a look at the rest. So obturator externus just there. So again, you can see those little strands of nerve fiber piercing into the muscles. So they supply obturators externus, adductor brevis, longus, and then the anterior portion of adductor magnus. And if you think about it, that makes sense. If I just go back to that one, pause it there. So because of where the obturator nerve comes through, it kind of, the adductor magnus kind of covers that whole medial aspect of the thigh. And there's an anterior and posterior portion of adductor magnus. So it would make sense that the obturator nerve supplies that part of the muscle, because otherwise it would have to go round the back to supply the posterior part of adductor magnus. Okay, so that's where that one pokes through. Cool, right. Still with me? One more. Sciatic nerve, here we go. You've probably heard of this one. Most people have. So the sciatic nerve, this is an interesting one because you'll notice there are no sensory nerves apart from in the lower leg. So there's no sensory nerves on the back of the thigh from the sciatic nerve, which sounds a bit weird because you would expect it to be there. But there are another couple of nerves that do that specific job. So we're going to have a look at those in a sec. So there are 4 motor nerves, and that's it. Yeah, so the sciatic nerve in the thigh, so affecting the knee, only affect these muscles: biceps femoris, semimembranosus, semitendinosus, and adductor magnus. So and remember what we said about adductor magnus being your 5th hamstring. So 2 heads there, one there, one there, and one there. So that posterior part of adductor magnus acts like a 5th hamstring. So will help to extend the hip. And that's all it does. That's all the sciatic nerve does. So you've got a whacking great big nerve that supplies 4 of the biggest muscles in your body. Okay, so it's a pretty good design. So sensory wise, none in the thigh. It does provide sensation, however, to the leg when it divides, and we've had a look at that in the foot and ankle. So when you get below the knee and the sciatic turns into the tibial and peroneal nerve, that's when you get cutaneous branches coming off of those. Okay, so there's nothing coming off of the sciatic nerve. Oh, jumped ahead. Save that one for later. Right then, let's have a look at this. Sciatic nerve. Okay, so I'll split this into 2 parts. So we've got the kind of hip part and the origin of the sciatic nerve, and then the knee part and the leg part. Okay, so and we'll finish at the knee because obviously we've covered the rest on the previous videos. So orientation again. There's your femoral nerve. That's your psoas. Okay, obturator looks like it's that one there. And then if you see these at the back, see those ones there? That is the start. So those are the roots of the sciatic nerve. So let's have a look at that. So there you go. So if I just pause that there. So the sciatic nerve comes from L4 all the way down to S3. And you see how this works, yeah? So you've got a branch here, one there, one there, one there, and one there. And when we get to the lumbar spine, we'll go into more detail about how these are all arranged, because there's some nerves that come off the front, so they're called anterior rami. Some that come off the back, they're called posterior. Some that join together. So if you remember the brachial plexus when we did that, and there was a lot of crossing over and mixing of the nerves. We're going to go into that in a load of detail when we get to the lumbar spine. All right, so we'll cover all that then. But for now, this is all we need to know. So we've got L4, L5 coming together to form a nerve there, and then S1, S2, S3, and then they all come together to form this big blob of nerve tissue. And that big blob of nerve tissue is your sciatic nerve. This bit here is your greater sciatic foramen. There's your piriformis muscle just there. And that there is your sciatic nerve. Don't worry about the gluteal nerves. We cover those when we get to the hip. So greater sciatic foramen is the hole that the sciatic nerve will go through, and we'll cover that again when we get to the hip and pelvis, so don't worry. There's your big glute max. And then with that taken away, you can see where the sciatic nerve comes through. There's your piriformis, pain in the arse, pain in the butt, sorry. Sciatic nerve just there. So this is really, really thick. This is, like I said, the thickness of your thumb. So you've got a little rotator muscle there called quadratus femoris. And then the sciatic nerve runs over the top of that. And if you see here, these are the muscles we looked at before. So that's your biceps femoris just there, okay? And the sciatic nerve goes underneath that hamstring muscle. There's your back side of the adductor magnus, so the posterior aspect, long head of biceps femoris. And that's it with the biceps femoris taken away. So it supplies your semimembranosus, semitendinosus, biceps femoris, and then the posterior aspect of adductor magnus. So that adductor magnus, just pause that there, is shared with the obturator nerve. Okay, so they both share that muscle. The obturator does the anterior part of adductor magnus, and the sciatic nerve the posterior part. Okay, cool. And then the last bit for this, this is the bit by the knee. Okay, so that you've seen where the sciatic nerve goes deep to the biceps femoris. This is where it comes out. So there's your semimembranosus semi-10. There's your biceps, and there you can see the sciatic nerve coming through. So gastrocnemius heads, that's your popliteal fossa, that diamond at the back. There's your sciatic nerve. So that's where we saw it before, and then that's where it's poking through there. So it actually goes through, just pause that there. So you've got the long head going up to ischial tuberosity of biceps femoris, short head on the linea aspera, and then they both join together. The sciatic nerve goes in between those two biceps femoris muscles, so in between the long and the short head. Ooh, there's your popliteal artery and vein, so we'll cover that next week. And then you see here where it splits into two, so then you've got your tibial nerve and then the common peroneal nerve, and that's what we looked at when we did the ankle and foot, so we've gone down. So there's gastrocnemius, and you can see the nerve coming through and going into those muscles. You've got a branch coming in there, and then the peroneal nerve coming down this side. That's your biceps femoris tendon just there. So the common peroneal nerve wraps around your fibula head. Cool. So that's where the sciatic nerve comes out at the back, just there. And then the tibial nerve in the knee supplies your popliteus and your gastroc and the plantaris, which are all those muscles that we've been looking at over the last couple of weeks. Okay, and I think that's it for that one. Yeah, perfect. Cool. We've got two more things and then we're done. You've done really well. This is a hard session, this one. Okay, so two more. And it's to make up the rest of the sensation. So if you think about it, the obturator nerve was sensation for the medial part of the thigh. The femoral nerve was medial and anterior. So then, but the sciatic nerve didn't provide any cutaneous information at all. So no sensory nerve there. So what supplies the sensory information from the back of the thigh? Well, it is this nerve here. Okay, so it's the posterior cutaneous nerve of the thigh. Does exactly what it says on the tin. Okay, so we've got posterior at the back, cutaneous, which means skin, and then obviously nerve of the thigh, so nerve of that thigh region, so that femoral region. Now, this comes from S1 to S3, and it is purely sensory. So remember when I was saying about the wires on the other one, and you have a live wire and a neutral wire, one's motor and one's sensory. This one has only got one wire. Its only job is to provide sensation from the back of the thigh and some other areas as well. Okay, depending on the branches. So we've got 3 branches. We've got posterior thigh. There's a gluteal branch which supplies the sensation for the lower part of the buttock, so around the glute max area, and then there's a perineal branch, not to be confused with the peroneals. That's why we call them fibularis now. The perineal and peroneals are 2 very different areas of the body. And then we've got, so these 3 areas are all supplied by this posterior cutaneous nerve. Okay. This is an interesting thing. So when you get a shared nerve, you can get some mixed messages. So pelvic pain, so scrotal pain or genitalia pain basically can masquerade as sciatica because of the shared parasympathetic pathways at S2 and S3. So basically, because you get this genitalia branch and you get the cutaneous branch of the posterior thigh all going into the same area, sometimes the body gets a bit confused as to where the information is coming from, and it will make your back of your leg hurt like sciatica, but actually you may have some pelvic girdle issues. So this is why something like, I've been banging on about Safety Net, the questioning tool that we've put together. It asks questions about the genitalia, which you wouldn't necessarily think about when someone comes in with sciatica type symptoms. Okay, so it's something to think about. No probs, Al. So if you have a feeling at the back of the thigh, it won't be an issue with the sciatic nerve. Nope. Interesting, eh? Yeah, it's not to do with that. Yeah, which is really interesting. Loss of sensation there. Yeah, won't be to do with the sciatic nerve because there's no posterior. There's no cutaneous nerve there. Cool. Never twigged before. Irritation of the sciatic nerve, etc. works on a nerve that is motor only. Wouldn't have guessed that. Yep, exactly. Yeah. It's interesting, isn't it? No probs. Yeah. Sorry, guys. I got one more thing, and then you're done. I knew this was going to be a long one today. Okay, last one. The only other bit that's left is the outside of the thigh. So the lateral aspect of the thigh, L2, L3, and it's called the lateral cutaneous nerve. Now, the interesting thing with this is it runs underneath the inguinal ligament and can get trapped. So it's a bit like carpal tunnel of the thigh, and you'll have a weird sensation on the outside of your thigh there, okay? And that's purely cutaneous. It doesn't have any motor branches. Yeah, so we've got the posterior cutaneous nerve at the back of the thigh, the lateral cutaneous nerve on the outside of the thigh, femoral nerve, obturator nerve, and that then completes the sensation for all of the thigh. Okay, cool. In the calf, Penny, you'll have to have a watch back of the nerve video for the leg, okay, because that's all in there. So that the sciatic nerve will give you strange sensations in your calf and your leg, yes, but not in the back of the thigh. All right, cool. Thanks, everyone. That was a monster today. So we've got blood supply. We'll do a little bit of a recap of the nerves next week, and then we'll go on to the blood supply and finish off the knee. So I hope you have a good week. See you next Monday, 10 o'clock.